And
okay, you stated that you are BLS certified. So
yes, sir.
what you studied over there that differentiates in your working?
Sure, sir. So basically, normally most of the medicos are aware of the basic life support system, but being a BLS certified provider, we were first of all taught on dummy models how to implement the basic life support system. Then, apart from that, we had got the chance to give CPR and various stages of the basic life support to patients in the trauma ICU as well as the anesthesia ICU. So I have given CPR and basic life support to implemented it on various patients on the field as well as off field. So I have a better experience and a better exposure. I have learned from experts. So I have a better exposure and a better understanding of the various things, not only on a dummy but on the real patients as well. That gives me a better edge than the other colleagues of my same cadre as well.
Okay.
Yes, sir.
Can you classify anemia?
Yes, sir. Sure. So, anemia.
For men and women, you can classify.
So, yeah. Okay. Sure, sir. So anemia, basically, I can classify it depending upon the etiology. Basically, we have microcytic anemia, macrocytic anemia, and normocytic anemia. Basically, this depends upon the RBCs which we are getting affected. Microcytic anemia is when the RBCs have normal, a slightly lesser shape than normal. It is, we have the MCV normal than the range. Then we have the normocytic normochromic anemia, where we have the size and color of the RBC similar as that of the normal RBC. Then we have the macrocytic normochromic anemia, where the size is normally larger than the normal RBCs. In this, for example, we can take as megaloblastic anemia, where we have deficiency of vitamin B12 and folic acid, which leads to there is a defect in the pathway, which leads to formation of very large megaloblasts in the formation of the erythroblast, which leads to formation of megaloblast, and hence we have megaloblastic anemia. Then in microcytic anemia, we can we can say there are sickle cell anemia, which is a normal, smaller than the normal size. Sickle cell anemia is basically due to the defect in the hemoglobin chain, which leads to formation, which leads to breakdown of the RBCs, resulting in the sickling of the RBCs. Hence, there is the RBCs are able to carry less oxygen as compared to the normal because of the smaller size. But the sickle cell RBCs, there is a slight advantage to the people living in the African population, hence because they give a better life, and there is a better morbidity rate in the people out there, because the malaria antigen is not able to survive on the RBCs. Hence, there is a better edge over them in the people suffering from sickle cell anemia out there. And normocytic normochromic is slightly the functioning, the anatomy of the RBC is same, but there is a defect in the physiological aspects of the RBCs. Hence, we have a normocytic normochromic RBCs.
Okay, tell me about fibroids, its factors, and even the management.
Yes, sir. So fibroids, basically these are benign tumors of the myoma of the uterus. These are of various types. There is a FIGO classification depending upon the location of the fibroid. When we have a submucosal, subserosal, and an intramural fibroid. When it's less than 50% of the inner layer of the uterus, then there is more than 50%, and then it's more than 50% of the outer layer. Depending upon the involvement, we can divide into various types. Depending upon this, we have the classification. Then fibroids are basically benign tumors. Clinical features we have in this, that is, patient may present us with painless bleeding. The patients do not have much signs and symptoms. Sometimes there is chances of difficulty in conceiving. Sometimes the patient presents to us during the after conceiving, when she is 2 to 3 months in the pregnancy phase, in our first or second trimester, when she has some difficulties because the leiomyoma or the benign fibroid interferes with the growth of the fetus in utero. Then for management, we just need to follow up the patient. Most of the fibroids regresses with age. We don't need to, as long as it doesn't hamper us or it doesn't cause any problems or it doesn't turn malignant, we can give the patient symptomatic treatment. And for management, if there is any patient is having symptoms and it is interfering with the patient's lifestyle, then we can go for medical as well as surgical management. For medical management, we can give her tranexamic acid for any bleeding. Then for pain, we can give her mefenamic acid. And for pain, we can give this. For we can bleeding tranexamic acid. And for surgical management, we have myomectomy, where we remove the where we laparoscopically remove the fibroid from the uterus. And uh, in 2 to 3 months, the patient gets back to normal. And after 1 year, we can say the patient can conceive back after the surgery.
Okay, speak on varicose veins.
Yes, sir. So varicose veins. So basically, our body has a venous system, venous channel, through which the deoxygenated blood gets traveled back to the heart. And as our limbs are due to gravity, our lower limbs, they have large venous channels. And due to any certain causes, it can be inheritable or it can be any autoimmune causes, or due to long standing patients with who have certain professions who have in which they have to stand, the perforators and the channels, they get defected and they are not able to transfer the blood from the peripheries to the heart back. Hence, there is dilatation of the venous channels, and the valves get incompetent, and there is pooling of the venous blood in the veins, which leads to enlargement of the veins. Hence, as long as the patient doesn't have any signs and symptoms, we can just give them symptomatic management. If the patient has any starts having pain, limb claudication, that is pain during rest or pain during walking, then we have to go for surgical management. For surgical management, we usually go for we strip of venous channels, and then we after removing the venous channels, the perforators develop alternate channels through which the venous blood can be traveled back to the heart. Hence, we remove the visible venous channels, and the perforators and the side channels help in transferring the venous blood back to the heart. That's it.
Types of myocardial infarctions, am I?
Sure, sir. So basically, myocardial infarction is decreased blood supply to the muscles of the heart, leading to death of the heart muscles, leading to a myocardial infarction. It can be further divided into non-ST elevation myocardial infarction or ST elevation myocardial infarction. Basically, if a patient comes to us with jaw pain radiating to the left arm, with these clinical features, we go for 12 limb ECG along with symptomatic management like oxygen, IV fluids. As we take the 12 lead ECG, on that we see if there is any ST elevation. Our immediate management is we go for morphine. We give the patient morphine, and we give oxygen 90 to 95% saturation, and aspirin 325 mg, and nitrates. Along with that, we can give warfarin and statins. If there is no ST elevation MI, then we go for troponin levels. If their troponin levels are raised, then it's a non-ST elevation MI, and if the troponin levels are not raised, then it's an then we go for both the managements. We go for uh, antiplatelet therapy like thromboxane A2, clopidogrel, and then we go for stent replacement or stent placement in the patient. If the patient is less than 2 hours, then we go for percutaneous intervention, that is percutaneous placement of the stent. If the door to hospital time is more than 2 hours, we immediately need to put him on anticoagulants and antiplatelets first, then we need to take him up for surgery.
Speak on cold chain.
Sure, sir. So basically, we have various type of vaccines at our various centers. So at our PHC level, basically we have various types of methods to keep the vaccines, from ice-lined refrigerators to deep freezers to cold vaccine boxes to ice packs. And main, we have to maintain a cold chain from the source, that is from the vaccines are manufactured. Like in India, we have the Serum Institute of India, from where the vaccines are mostly manufactured and distributed throughout the country, to the last source, that is the PHC or the subcenter. From there, we need to maintain a cold chain so that the vaccines are maintained and they don't get spoiled. At the individual vaccine level, on the vaccines, we have a VVM known as the vaccine vial monitor. It has a vaccine vial monitor. It basically shows, it has a color coding on it. As if the color is less than, it has a inner square and outer box. If the inner square color and the outer box is different, that is the inner square box is always should be lighter than the outer box. As soon as the inner color box and the outer square becomes of same color, then the vial should be discarded, it should not be used. Apart from that, at the deep freezer level, we have to keep the vaccines mostly in the freezer. That is at 0 to -6 degree. That is a normal fridge temperature. And apart from that, we certain vaccines we need to keep it at very low temperatures, around -20 degrees centigrade. That can be kept at a deep freezer. So the vaccine which need to keep it at a lower temperature, we keep it on the lower side of the deep freezer, and the vaccines which we need to keep around 0 to 6 -6 degree, that is normal fridge temperature, we keep on the upper layers of the deep freezer. Along with that, we have a meter which always looks at the temperature of the deep freezer, so that in PHCs, if there is any uh, electricity supply shortage or there is no electricity, the refrigerator can maintain up to 24 to 48 hours of the temperature on cold temperature on its own. Hence, along with that, the temperature monitor on the outside can be read by a lame person. If any expert doctor is not present at the hospital, the normal person seeing and giving the vaccines to the various people can identify and look for the if the vaccines are kept at a proper temperature or not. Yes, sir. Sir, not audible, sir.
Okay. Glasgow Coma Scale.
Yes, sir. Sure, sir. So basically, the Glasgow Coma Scale is basically used for assessing a patient's ability to, if he or her has had any injury or any road traffic accident, we need to assess the patient's score at that time. It tells us how much the patient is responsive. So it is a generalized score used all over the world to tell how much the patient is responding. It is divided into three parts, and including one more, which is a newly added score. Mainly, we have the motor response, the verbal response, and the MV and the eyes response (EVM). Along with that, a new response has been added, known as the pupillary response. Total Glasgow Coma score is 15, sorry. 15 is the total score. And along with that, a new pupillary score has been added if the pupils are of the patient are closed or not, or responding to light or not. If the both the pupils are responding, then it's 0. If one pupil is responding, we subtract this score from the original 15 score of the GCS to tell us the exact score which we are getting. So eyes, we have the six types. Verbal, we have 5 types, and the motor, we have 4 types. And on totaling, we get 15. And apart from that, 2 is for pupillary response if we add or subtract. 15 to 12 is a normal. Then if we come lower than that, 12 to 8 is slight, patient is slightly not responding, and less than 8 is completely not oriented to time, place, and person, and immediately needs ICU care.
Okay. Tell about Red Cross Society.
Sure, sir. Red Cross Society. So I need to study about it.
Can you tell something about road accident trauma?
Yes, sir. So basically, in India, road traffic accidents are one of the major causes of death throughout the country, owing to such large highways and roads with people traveling so much. We have a large number of road traffic accidents throughout the country. The government has developed various measures to control it, but still we have a large number of mass casualties catering to road traffic accidents. So we have various response schemes as well developed for road traffic accidents, so that people can, as soon as there is any road traffic accident, they can be immediately referred to any nearest center as well. The government has implemented various schemes like introduction of all 4 to 6 packs compulsory airbags in cars to for the proper safety. Various road traffic measures are there to for the safety of the people. Apart from that, people having road traffic accidents are a major source of mortality and morbidity in our country. There is a large number of head trauma cases catering to the road traffic accident in our country. Hence, we have various scores for people having any road traffic accident to check what is the status, like the Q-SOFA score, Glasgow comma score, this comma scale, and the revised trauma scale. For that, the government has also introduced like the basic life support. For people should be aware of the basic life support, so that anyone in need of accident or any need of there, we can give to them. Then any responder team available is there, so they give the advanced trauma life support. And in this earlier, our focus was mainly on the airway, breathing, and circulation. But now there is a more emphasis on the stability as well. That is a cervical component. If because a large number of people having road traffic accident have a cervical component involved, so hence we have to give a importance to the stability of the neck, so that there is no movement of the neck, and we can stabilize it and shift any person of a road traffic accident to the nearby healthcare facility available.